I think that this is a really important question in the real world. Although the data is overwhelming and compelling that you should start an immunotherapy with your very first treatment in advanced disease for the majority of patients who don't have an oncogenic driver, we have 8 randomized trials showing that the combination with chemotherapy is efficacious, as well as 3 trials showing that monotherapy also is a reasonable first choice option. And so that is a lot of data, but in the real world, our patients don't always follow that clinical trial playbook, and sometimes we can't actually start the IO in the actual cycle 1, which is how they were started in the clinical trials. And in my presentation, I gave 2 real-world examples of a patient who was supposed to start his chemo IO, fell, broke his hip, required surgery, but was symptomatic, and so we ended up treating him in the hospital just with chemotherapy. And then another patient who was younger, but very symptomatic with a lot of disease burden, may have had a actionable mutation, but was not willing to wait even a week to get that resolved. She was very symptomatic, anxious, and so we started just chemotherapy alone without an IO. And then you're faced with that dilemma of, well, when do I add that IO now? So should I put it with the second cycle of chemotherapy? Both patients had responded to their first cycle in terms of symptom improvement. Therefore, could you wait and do it in the second line setting?